Hi, everyone, and welcome back to Fit to Fellowship, the survival guide for the first year general cardiology fellow. I'm Megan, and this is Stacy.
Hi, everyone.
And welcome back.
And today we have Dr. Evans with us live to answer the questions that have come through regarding his lecture on tachycardias and bradycardias. So let's just go ahead and jump right in since we have Dr. Evans with us. Thank you so much for being here. So the very first question we had was about MAT, multi-atrial tachycardia. So what is the harm of MAT? Is it cardiomyopathy from tachycardia? Is there a stroke risk associated with the rhythm, just as there is with AFib and a flutter?
So MAT is mostly a marker of high mortality and events to come. So there is not a good natural history of what MAT itself causes, but there is some data. About 60% of people with recorded MAT have a 1-year mortality, or about 60% will die within 1 year. 55% actually will progress to atrial arrhythmia. So the bottom line is normally we're treating the underlying cause. We try to slow things down. Typically, MAT is a marker of disruption in other organ systems, particularly the lungs. So usually the mortality is driven by the other organ system. If it continues, we really worry the patient's demise may come very quickly based on other organ systems. The risk of stroke, we don't think is the same as atrial fibrillation, because even though the atrial activity is somewhat chaotic, there is a period of standstill in between the atrial beats. So atrial function should be maintained. So it's not recommended to anticoagulate people unless they're diagnosed with atrial fibrillation. And as I mentioned, about 55% will proceed to atrial fibrillation.
Got it. Thank you.
Fantastic. So the second question is in regards to high-grade AV block versus complete heart block. Can you clarify again the difference and similarity of high-grade AV block and complete heart block? What about isorhythmic dissociation?
Okay, so high-grade AV block basically is when you don't have complete dissociation. The similarity is going to be you're going to have several P waves before you get a QRS, and the biggest difference is that the ventricular rhythm has some irregularity with high-grade AV block. There's some evidence of conduction. You can bring in an early QRS occasionally, but the high grade isn't always the exact amount of block. So sometimes you'll have 4 P waves, and you'll have 2 P waves. But if you're getting numerous P waves before the QRS, that is when we will say high grade if there's any acceleration in the conduction. The other similarity is it's an indication for a pacemaker in and of itself from being AV block causing a slow heart rate. The biggest difference is that typically you're going to have a normal QRS or a regular QRS rhythm. The QRSs are going to have a regular escape with complete heart block. So it's typically an irregularity of the escape. Some beats are going to come in early. And with the isorhythmic dissociation, that's when you have sort of an A and a V rate that are very similar to one another. One may be faster than the other, but they just aren't marching through enough that you get a chance to see whether the A can conduct to the V. There's an atrial rhythm and a ventricular rhythm that are close enough in rate that they're marching out side by side.
Excellent, thank you.
Okay, next question is about the sinus exit blocks. So it seems that P waves can be dropped or P waves can come in dissociated from the QRS complex. Patients with this rhythm, do they require pacemaker placement if the rhythm is seen, or only if they're symptomatic?
So I'm going to share my screen here if that's okay.
Sure. Let me stop screen. Stop share. Go ahead.
And let's see, share screen. I'm just sharing an image from the internet here. The example here, basically you're going to see grouped beating if you have sinus exit block the vast majority of time, or sometimes you can see an abrupt cut in half of the rate if you were dropping every other P wave. You can go from a heart rate of 60 to 30 with the conduction being 1-to-1. So this is only disease at the sinus node. So grouped beating is the hallmark of this and recognizing it. And because this is an example of sinus node dysfunction, pacemaker is dictated only by symptoms. There's nothing you necessarily need to do if you see this. Sometimes when somebody has sinus node dysfunction manifested as sinus bradycardia, people will hold the nodal blocking agents or other medications saying, hey, maybe this is going to get better. When you see sinus exit block, usually that's a manifestation of structural disease as well as functional or pharmacologic effect. So this typically is going to represent a patient that you don't really need to hold things. This is most often going to be a fixed issue unless there is something readily reversible like hyperkalemia. Hyperkalemia can do this occasionally, and that may be reversible. But in the absence of a readily reversible electrolyte abnormality, the beta blocker is not going to give you the exit block like this. It's going to slow you down.
Excellent. The next question has to do with transvenous pacing, or TVPs. And it is, are there any contraindications to placing TVPs?
So the way I think of TVPs is essentially not doing harm. So the only relative contraindications are if there is limited venous access, if you're only on the side of a AV fistula, but there is not a strict contraindication to pacing one. Our goal is to sort out when there is benefit. Obviously, everything has an evaluation of risks and benefits. If we think that the benefit is minimal, then your risks are way outweighing the benefit. So in a patient without an indication, so if they don't have any hemodynamic compromise from whatever you're seeing, that's when I wouldn't do it. I think if there's any hemodynamic compromise and you feel there's any chance that it could be repeated, then it is reasonable to consider, and it's relatively low risk to do. Again, sometimes the pathway to the heart is somewhat obstructed, or there may be high pressure in the area you're going if there is hemodialysis access, but in general, no firm contraindication.
Great, thank you. Next question is about non-sustained ventricular tachycardia. So what is considered a short run of NSVT versus a long run of NSVT? And what does it mean to have recurrent runs then? Oh, yeah. Short, I guess, versus long, yeah.
So my answer from the EP's perspective is a short run is 3 beats, because that's the shortest. If you're tachycardic and you get 3 beats, that counts as NSVT. A long run is how many ever beats you get in 29.9 seconds that stops immediately before. After 30 seconds, it is sustained. Now, I'm giving those extreme answers because once you get to 3 beats, you likely have either some pathway for reentrant tachycardia or some mechanism for continued tachycardia. So you have defined yourself with the ability to have numerous beats in a row once you have 3 beats in a row. A repetitive episode, having it more than once is confirmation that this possibility exists. But anything that has non-sustained VT as its indication for what we're doing, 3 beats counts. And once Once you're over 30 seconds, it's sustained. So we're looking at maybe secondary prevention of events because people are having sustained VT. There's not a huge difference in what's predicted by a 29-second episode versus a 3-beat episode. So non-sustained VT, I think you should think of as non-sustained VT. Now, every time you have it, there's a probability that it's going to sustain. There's a probability that it could deteriorate into an unstable situation. So having repeated episodes increases your probability of that. And one of the biggest things that I think of is heart disease patients with non-sustained VT, patients that have ischemic heart disease. There is a higher EF where we could consider doing an EP study looking for inducibility to consider placing a device. Otherwise, it's a marker as much as it's anything.
Great, thank you. Fantastic. And then the last question deals with wearable defibrillators are also called life vests. So when should we consider sending patients home from the hospital with a life vest?
This is a really interesting question. It's very tied into money in the answer. So you can look at the guideline statements. The two-way indication from guideline statements is in somebody who has a device for secondary prevention where the device needs to be removed, but you're still doing secondary prevention, it's reasonable to consider. Now, interestingly, when you look at the survival curves, even of secondary prevention, folks, the event rate in clinical trials in the control arms initially, when we started doing secondary prevention devices, were in the 10% per year range. So a month of the device is going to have at maximum a 1% event reduction in the highest risk patient. So I really try to reserve it for the patients that I think are having sustained arrhythmias, recently having many, many treatments for the arrhythmia. Now, there's a 2B indication for people who have an indication for a defibrillator pending. Basically, people who have a low EF that they are waiting for their 3-month evaluation, or to be 40 days from revascularization. The issue with this for me is that the event rate is actually very, very low. The home AED trial looked at giving people defibrillators to use externally at home, and they tried to pick the highest risk population they possibly could, which was an immediately post large anterior MI population. And their event rate was so low that they wouldn't be able to show anything. So I personally usually don't use them a lot, but it's more of a financially driven decision. Just in terms of being a steward of resources, the event rate is incredibly low. There is the flip side, the emotional decision of, oh my goodness, if you can order 1,000 of these and save one life, why wouldn't you order 1,000? And my answer is because that 1,000 of these is somewhere around $3 million. So it's several thousand a month, and even if the patient's insured, somebody's paying the cost of this. And so, it's a healthcare utilization question. I think it's a great technology, and it's a nice thing to have in the very high-risk patients. Some people, it gives them the peace of mind to get out of the hospital and things, and they just don't want to leave without something. It's high risk to reimplant immediately, but it's more when I can treat somebody's peace of mind than when I'm treating their risk of arrhythmia, because usually the risk of arrhythmia isn't that high to justify the cost to me.
Fantastic, thank you.
Thank you for such thorough answers for all of the questions that we've thrown at you, Dr. Evans. This concludes our Q&A session for this talk. Dr. Evans, thank you again so much for being here. for teaching us, but also answering our questions.
Thanks for having me.
Thank you again, Dr. Evans. Excellent talk, excellent Q&A. And thank you again to all our viewers. Next week, it's going to be Dr. Short, Lindsay Short from the University of California, Riverside. And she'll be going over ventricular arrhythmia. So we're very excited about that. So stay tuned. Thanks.
Take care, everyone.